It's a great honor to be with you here tonight. So is this where I give the main first talk and then do the other people introduce themselves later then, or?
Yeah.
Okay.
You know, let us say that the last time we did this, last month, we got some feedback from some of the group here that they would be really appreciative of knowing who is in the room. And so we thought maybe tonight, instead of saving our introductions and questions to the end, that we would like go around the room now and just tell a little bit about who we are and why we're here tonight. You know me, so Amber.
I'm Amber Jackson. I'm a hospice volunteer with Partners Hospice.
Oh, great.
I'm Mary Werner. I'm a music dietologist at St. Patrick Hospital, part of the spiritual care department there. Playing a part for patients and families.
Okay.
I'm Nan Byington. I'm a Hospice of Missoula case manager.
I'm Carla Abrams, and I live here in Missoula.
I'm Lee Metzger. I'm a civilian also.
Okay.
I think this is my 5th meeting that I've been here, and I found it very, very helpful. Very fun.
I'm Nikki Fay, a cancer caregiver from Seattle, and now a cancer survivor here in Missoula.
I'm Melissa Thomas, and I just like to hear and learn all I can.
I'm Keith Brown. I'm a CNA with Hospice of Missoula.
I'm Curtis Peters. I'm from Utah. Actually, all 4 of us are. I actually work at Hillside Healthcare. I'm a life enrichment assistant.
I'm Josh Simpson. I'm the director of nursing with Hospice of Missoula.
I'm Nancy McCord. I'm a social worker and I work at Hospice of Missoula.
I'm Jill, and I'm a nursing student, and it's my dream to work for hospice.
Oh, yeah.
Yeah, great.
Good.
Excellent. Well, thank you very much for sharing on that. And before we talk about my experience in Mongolia there, I would like to share a little bit about some personal experience that's happened with me this week. About Thursday of last week, I got a phone call from my mother saying that my father was not doing very well and really asked me to come right away. And they don't live locally here. They live in southern Florida. And so that was a quick turnaround, and I was basically there in southern Florida in about 24 hours there. And to my shock and horror, when I got to the hospital and seeing my father, it was the last time I talked to him on the phone. He was just talking normally, and he actually walked into the doctor's office just a couple days before then. He was there in a bed, hooked up to a whole bunch of tubes and having just this agonal look on his face. And to make a long story short, he got a urinary tract infection, got urosepsis. Urosepsis went into his spinal cord, created cord compression on there, and it was just really in a lot of agony. At that time, we were still trying to press forward with IV antibiotics and getting neurosurgery and everything involved, just to try to relieve his pain, because it was just awful to see him suffer like that. And he couldn't really talk. He was paralyzed, but just that look in his eyes of just knowing that he was really suffering. After about 2 days of that, it became quite clear that this was going to be a terminal illness, that no matter what medically was out there, that he would not be able to recover from this. But just to tell briefly about the experience of working with hospice-type caregivers during that process. And you know, the doctors would come in, especially the infectious disease and neurosurgeons, and be very clinical and say, well, he's getting better, lab values are getting better, and all these things. But you look at that person in the bed, and he was not getting better, and he was suffering. But when you had people like social workers or the quality of life people coming around, or the representatives from hospice, there was a different attitude with those workers. Even in the way they talked, the way that they would touch you, the way they look at you in the eyes, the way that they just had a whole aura of compassion around them. And I can tell you, as a son of my father, that was extremely comforting and reassuring. Now, as it turned out, actually hospice did not get involved because the day that they were going to take him to hospice, he actually died, which I'm very grateful for. He was suffering. But I just want to say, even from this week, that I've seen the value of hospice from a personal standpoint, and to know that there is an option for people who are really suffering, and there isn't much more medically that can be done, but you can definitely make their last few days on this earth a so much more comforting experience, not only for the patient but also for the family, because you know, sometimes the family don't always have the best, you know, big picture about, you're trying to do everything you can to help that person, and someone outside that can say, you know, that, well, maybe this is all that can be done, and don't feel guilty about that, but we just want to make your loved one comfortable, and that's okay, and for them not feel guilty about that idea. So all of you who are either kind of thinking about hospice or already involved, I think you know these things, but it's a very noble work. It's a very needed work, and unfortunately sometimes American culture at large still doesn't really quite understand hospice. So I applaud you for wanting to be involved with it, because I think it's a very crucial part of the healthcare system that sometimes gets neglected in its value. So I just want to say that about that. All right, so Mongolia. So you might think, how in the world did I get there? Well, briefly, when I was a second-year resident in family medicine, we were on rounds one day, and my residency director, this was in the hospital, read out this letter. They were saying that Mongolia is a country that's newly opened up to Western ideas. They just had a democratic revolution in 1990. This was in 1992, and they said they had another family doctor go over there and ask them, you know, what kind of services were you be interested in to get some help and advice. And they said, well, we heard about this concept of a family doctor. We don't really know what it is, but we'd like to find out. So I went together with my residency director to Mongolia in December 1992, fell in love with the country and the people, went back there again the next summer and developed the first curricula there for the family medicine program, and then had their director of postgraduate medical education come live with me for a month in the States and showed them how we do family medicine. And then basically after residency, I did some missionary training and then went to live in Mongolia. I was a single at that time, met my wife there. She's from the Netherlands, and married in Mongolia. We have 2 adopted children from there, and just adopted a little baby here from Montana who's 3 months old now. So, so I was very active, involved in family medicine and working in the medical school, and doing different types of projects, and just kind of analyzing the Mongolian healthcare system. Now, if you know anything, which you probably don't know a whole lot about it, but Mongolia was not officially a Russian satellite state, but it basically was controlled by Russians. So it had a very Soviet model of medical care, a lot of subspecialization. You had dermatology hospital, you had an OBGYN hospital, you had a pulmonary hospital and things like that. So it was very much kind of a fragmented care. And as I mentioned, they never even heard of this concept really of a family doctor, and that was not even part of their system whatsoever. So this whole idea of kind of integrated healthcare, where you're looking at the whole person, the physical, the emotional, the spiritual, all that kind of stuff, was really a foreign concept there. And the other thing that was very interesting to me in looking at Mongolia is, I mean, worldview does make a difference about how you see a person. And there were 2 predominant worldviews in Mongolia at the time that I went there anyway. It's traditionally, from ancient times, really a shamanist, animist background. But in a more modern culture, over the last few hundred years, it was Tibetan Buddhist. And in a more modern culture than that, over the last 70 years, when the Russians came in, when they kicked the Chinese out, it was atheist. So you had this kind of mixing of these different worldviews there. Basically the concept in those different worldviews that were going on there is that, you know, someone who is dying, or they have cancer, or those kind of things, there's not really a need to show compassion to that person. And the reason is, if they're suffering, well, they did something wrong in a past life or something. And it was there both with kids. I mean, we had just awful things with kids with big cancers or handicapped people, and they were just shunned. They were just put in a corner, and there was no compassion for those kind of people, and especially for the dying. And even what basically would happen if someone were going to the hospital there, if they were diagnosed with an illness like cancer or some type of situation like that, they were sent home from the hospital and just sent home to die in a ger, the little tents that they live in, or at home. But there was no part of the system where there was any type of follow-up to help them to die with dignity, as we say. And you had people in terrible suffering. There was no narcotic pain medication available to any degree. And so people feared death. You would have people when they're getting their 50s and 60s. 60s was pretty old for Mongolia, and they don't have such a long life expectancy. And just seeing their fellow friends and colleagues and family, die terrible deaths. And so death was something really not to look forward to. And not so much different maybe than even in America back a few decades back. And so this whole concept of hospice or helping people to die without fear and to not fear that they're going to die with terrible pain was totally foreign. And I would not take any credit for getting this started. Actually, our Mongolian colleagues said we need to do something about this. And so the main doctor that I was working with there started to do some research on this and looked at models from around the world on this. And so we said, well, we don't have any money to do this, but we're just going to start small. So we just started with a couple patients, and basically the Mongolian healthcare system says you can do whatever you want with these people. They're out of the system. We're not going to have anything to do with them anymore. And one of the biggest challenges was actually getting pain control, because you could not legally import morphine or any of these other kind of things to help people. And it was a legal battle to get this into the country. And over time, the government did start to change its attitude on that, and they did have some certain people who were allowed to give that. But our hospice was one of those ones that was the first one. Actually, it was called Hope Hospice, and it was the second hospice in the country. There was one other one that was there a couple years before us, but the particular man that I was working with there was very much a leader in the medical system there, and so he was not only starting this Hope Hospice, but was a leader activist, basically, for hospice. He was speaking before government, before parliament, before leaders in the medical school, trying to change people's attitude about how people die. And so basically, we had this little van, and we just go from ger to ger, these tents, and just visit people, usually, every several days, and we would teach family members how to take care of them, how to do their change their clothes and washing them, and especially making sure about pain control, and really getting family members involved. And actually, the biggest impact we had probably is not with the patients themselves, but with the family, because anybody who loves somebody else, you don't want to see somebody die like that. And they were so grateful, not only because they didn't see their loved one die in pain, but that someone would care about their loved one when basically Mongolian society just kind of shunned those people, was a real ministry to the family. So, basically it didn't take too long before word got out about how this works. And there were multiple other Christian ministries that saw this too as a need in the healthcare system. And so the multiple hospices started. And then there started a hospice association, and then a national palliative care association. And our director went to the regional palliative care association meeting as a model in Asia about how you do hospice. And then he got on the medical school, and they actually started a palliative care department at the university. There's one university there, medical university in there. And I'm just saying that I'm purposely not taking any credit for it, because it was really a Mongolian initiative on this. I helped facilitate things, but it was Mongolians who saw this as a need and saw we need to do something different. And that hospice is still going. There's multiple other hospices, and actually, as I understand it now, that hospice care is now becoming part of the official paid-for Mongolian healthcare system. And that transition took about 15 years, actually, for that transition to take place. And it's spreading to other Asian countries. So I'm not quite sure. You probably know more than I do. I don't know exactly where hospice started, where in the world it started. If it started here, I'm not sure. But it is spreading in Asia. And And I've seen how practically it helps people, it helps families, and it's needed. And I know I was sharing with you before that, when I was in training, hospice was a new concept, relatively new. And just glad to see that it's here in Missoula, that it's become an accepted part of the American medical system. And hopefully, it'll become worldwide, because there are still people, lots of people around the world that are dying terrible deaths unnecessarily. So that's the short version of what's going on.
Well, thank you. Dr. Ihrig, one of the things, of course, of primary concern for hospice professionals is pain management. And my question comes up, if they weren't using narcotic medications for hospice care, were they using them for acute care in other situations? And were they available then, but just not to you out in the field, so to speak?
Even in acute care settings in Mongolia, there was limited availability of narcotic pain control. So being in the hospital was a terrible thing for people. And I hate to say this, but pain management was reserved for under-the-table payments. And basically, if you did not, because physicians are paid so low in that country, the only way, and I certainly understand how this could happen, the only way they could feed their families is to have systems where families would have to pay under the table to get certain care. I mean, terrible things like, if you did not pay under the table and you didn't have the money, you get the operation, but you get the operation without anesthesia. And they were having, I knew friends of mine, Mongolian friends, who had appendectomies and different things without anesthesia, because they didn't have family members who could pay for the pain stuff there. And I know it sounds barbaric, but that's honestly how it was. And there was narcotic available, but not universally. It was for people who could pay those kind of bribes, basically.
Was there any alternative to narcotics that was effective for pain in a hospice situation?
There probably are. We couldn't diversify too much. It was such a big battle to get the morphine in there. And maybe now it's better than that. But that was the chief one, to try to get a system in place where it wasn't being abused, it wasn't being getting gangs or the mafia or whatever involved with that, but that we could use it in a legitimate way without it being seen as a trafficked item.
So showing a lot of interest in alternatives would have maybe diluted the effort to get the narcotic.
I think ultimately it needed to be done, but probably in the beginning it was so important to get some really powerful guns involved in pain management in the beginning. That was the center of focus.
Was this more rurally, or like in the city? Was this kind of the practice too, where you would suffer?
Yeah, it was actually worse in the rural area. I lived in the capital city called Ulaanbaatar, which is about 1 million people that live there. And these kind of practices I was talking about was in the capital city. It was worse in the countryside. So the big thing, honestly, that they used for pain management was alcohol. Vodka is readily available. The national drink, in a sense, called Ihrig, is a fermented mare's milk, which is weakly alcoholic, but vodka was readily available and pretty cheap. So people who were suffering, that was the way to kind of get them through.
Wow. I'm curious about sort of the dynamic that was behind your colleagues, your Mongolian colleagues, being able to sort of break away from the traditional view of death and acceptance of the neglect and suffering.
Yeah. Well, to be perfectly honest, my colleagues, the Mongolian colleagues I were working with, medical colleagues, they were Christians as well, and that was a relatively new concept too when I got there. But out of a Christian model of care and compassion, believing people are created in the image of God, every person, no matter what they look like, is worthy of dignity and respect. That was different than some of the other worldviews that were predominant there. Was how they broke out of the model on that.
I'm very undereducated about Buddhism, but I always have associated it with profound compassion. So I'm confused.
Yeah, that's interesting, isn't it? There's different forms of Buddhism too. That's a Tibetan Buddhist background there, but it's a dual compassion. I mean, it's interesting. In Mongolia, they have the boots that are turned up like this, so that you don't crush too many insects when you're walking. That's where they come from. But then you have human beings that are just kind of tossed aside, even like babies and stuff, if they have any defects. But I asked them, why don't you care about these people? And they said, well, they've obviously done something wrong in their past life. So why should we show compassion when the gods don't show compassion for that person? And I'm sure that's not worldwide, but that was the practical experience of that worldview, how it's worked out in that society.
But the individual families had compassion for
Absolutely, yeah, absolutely.
and didn't buy in.
The system did not show compassion, but individuals, sure, they loved their loved ones, and they wanted to see them not suffer like that. Yeah.
Kind of like here. Just continuing.
I think it's very remarkable that you were able, you and your colleagues, and as it spread out in the system in 15 years, make such a radical change. Because I look at hospice development, maybe just, if we say today, maybe 15 years back, we haven't come a long, long way. We really haven't. I think we're slower in our progression. And so that's quite remarkable. We made a big difference.
Well, it was a very interesting time. I love studying history, and to see so many things change in Mongolia over a short time, because basically they were, before 1990, Mongolia was probably one of the most closed countries in the world. You couldn't get in there as a tourist. You couldn't get in there at all, really. And to see such a transformation, not all of it positive, by the way, such a transformation in the culture over such a short time. You might be aware that they've discovered significant amounts of gold in Mongolia. And it's a mixed blessing. I mean, there are people definitely bringing some prosperity there, but also greed and not being as compassionate to your neighbor, and all the things that money and capitalism, all that stuff brings. It's there in Mongolia. It's coming. But generally being so isolated from any type of Western influence for so long, for centuries, and then just before my eyes to see so many things change was very interesting. And I think that's why it changed so fast, because there was just this vacuum of knowledge in a sense. And again, not every idea that came in there I think was a positive thing. Some of the things from Western influence is not necessarily positive. But for whatever reason, at that time, I think it had to do a little bit with the Russian background there and stuff, and some of the Cold War stuff, but they saw the West, and particularly America, as this nirvana type thing. Everything is good in America, and that was anybody who would send their kids to America, and so I think that's why there was such an openness for that kind of new ideas. Sir.
I don't want to take anybody. Oh golly, I gotta. No, I lost it.
It'll come back.
I'm sorry.
I have one, maybe it'll come back.
Yes.
Did you see similar, resistance or to dying, or just that need to make life as long as possible there? Or how was that maybe the same or different as you might see with your practice at community?
Resistance to dying.
Or just the need to seek out any possible way to extend
life.
prolong life.
Because the healthcare system is not as developed there, they saw death a lot, children dying. Just like when I read the Little House stories from here, it was common for you to have 2 or 3 or 4 children die. Whereas our culture now has been so insulated from death. There's a lot of people that have never seen somebody die ever in their life. And so that whole concept is so foreign. And anything that's kind of foreign creates fear and anxiety. And somehow I think we still need to get more of an integrated concept that death is a natural process for most people. And it's not something to be feared. It's not something that we needed to go to all technological costs to preserve life for another year or two. I mean, I'm sure you've seen some of the statistics about how much finances and money is spent in the last year or two of people's lives, and there's all this, thing about how expensive our healthcare system is. Well, I think part of it is because of people wanting to prolong death artificially to a little bit more extent, and not really accepting that death is a part of a natural process. And so that's my soapbox on that. But I probably didn't answer your question. But,
well, it sounds like you did that. It's kind of relative to privilege, and maybe our idea that all children live to adulthood is a relatively privileged modern concept, even for our country.
Yeah. Most of those people in Mongolia, because as I mentioned, when people are about to die, they're kicked out of the hospital and they go home. So most people had seen people die, whether it was a child die or an aunt or an uncle or a grandparent, and also because of them basically being a herder society, they're used to seeing death all the time, death in their animals. We have this thing called Zud, which is a terrible winter that comes every few years, and they would have millions of animals die, whole herds wiped out and everything. So they had to basically face death all the time, whether they're animals or people.
And it seemed like a natural process to send them home to die as opposed to dying in the hospital.
That was the natural part. The unnatural part was seeing them come home to die a terrible, painful death. And that's the part that nobody liked to see, but there wasn't anything being done about it. But yes, it was natural for them, more natural for them to die at home than in the hospital.
So what about, folk remedies? I mean, I can't imagine in the countryside where probably people not only doctor their animals themselves, of course, but their own folks, I would guess.
They did.
About all those things. We're so interested in indigenous medicine and cultures in the United States. I mean, they must have had some way of...
They did. And interestingly, still, especially more in the countryside, when you would ask what people really believe, it was still underlying a shamanist culture, worldview. So they have these practices about throwing the milk up into the sky to the sky gods, and most villages would have, in a sense, like a witch doctor. They don't call it a witch doctor, but that's basically what it is. And they would do some incantations and have some little potions and things, and it did seem to help, with the pain control and stuff. So they did have those kind of folk remedies like you're talking about.
Is anybody studying those?
Oh, I'm sure they are. Yeah, I'm sure they are. I've read books on shamanist practices in Mongolia, and I'm sure there's some sociologists and anthropologists that are studying those things.
Particularly the plant medicine.
There are, and also another big part, they actually have a separate tract in the medical school. That's what they call traditional medicine. And a lot of it has to do with herbal medicines, Chinese medicine. So you can be a medical doctor and be a traditional medicine practitioner there.
I'm curious about how what you came to know about their birth practices compared with how they saw it in life. Their
birth practices, again, very, kind of barbaric, and it has to do with traditional way. 99% of people, children were born in the hospital. They had this kind of birth home model where someone would come in from the countryside and live actually in the hospital for about 2 months. So obviously most of them would give birth in the hospital. Again, if there are any complications or any difficulties, only pain management if you can pay under the table. So you can imagine not just a regular birth, but if they had complications, you can imagine the amount of suffering that would go on with that. Terrible stories of people riding in on horseback from the countryside if they went into arrested labor and basically just using knives and things just to cut the baby out, and it was pretty barbaric at times, but most of them were born in the hospital. Sure.
Terry's comment about how slow it seems to progress sometimes in this country made me think of the resistance that we have in this country to aid in dying. And I was wondering if you encountered anything comparable to that resistance in Mongolia. I guess a philosophical aversion to palliative care or assistance.
It wasn't so much a philosophical. People didn't understand sometimes why you were showing so much care and compassion, but I wouldn't call it resistance, though. I would say it was more like apathy and just not really. And that was again more with the system, not necessarily with individual families. There was a great deal of interest with individual family members to try to help the dying family member. Yeah, but I wouldn't really call it resistance. You feel like we still have resistance in American healthcare? Do you feel like we have resistance still in American healthcare culture?
Absolutely.
There's much more resistance than acceptance.
We just had a bill in our state legislature for trying pharmacists and die.
So I think Lee's bringing up the topic of really physicians' aid in dying
Yes.
versus the comfort care model, if you will. So that was his question.
Right.
Was there an active, I guess, movement towards helping people who were suffering, maybe end their
Right,
lives
yes,
sooner,
thank you.
sooner than
Yes.
they otherwise would,
Right.
through medication
Right.
or other methods.
Right. Or if any of the activities that you were engaged in were seen in that light, and perhaps not. Yeah.
No, I don't think they were seeing that light. I mean, there definitely was not any type of either active or passive euthanasia type discussion going on there. Yeah, that wasn't really on the table that I'm aware of. Maybe it is now, but.
So did you feel that the activities that you were engaged in resulted in earlier deaths than might have otherwise occurred?
Probably more the opposite. That if they're able to get some pain relief, and the reason I say that, because I've seen people dying who are really, really hurting. I think there's almost and I saw it with my father just this past week, when they're hurting so much, often they just kind of give up their spirit. They just can't keep going on. But if they can get some decent pain relief, then I think sometimes people hang on longer, actually. Not always, but no, I don't think that in general providing comfort care hastens their death.
Sometimes providing pain relief allows them to go too, in some instances. Maybe it slows their system down. Not to help them go, but sometimes maybe the endorphins are so high or whatever that it's keeping them. But I was thinking about, and I hope this doesn't sound offensive or anything, but I was thinking about how you said the hospitals would send patients on to die, how barbaric it seems. And I suppose it is, the barbaric part is the pain, that they were in still, but I almost, I view that the system that we've created, that our society has created here, could be viewed as barbaric as well, because keeping people alive, with the hope, because there's not been that physician-family communication saying, we can keep your mom alive on a ventilator for years, but as soon as she gets an infection, or we're going to treat this infection, she's going to get it again.
Right.
And decreasing the quality of life, I think, almost to a certain degree, is just as barbaric.
I agree with you. I guess the barbaric part of what I was trying to describe is the idea that you would let someone suffer, go through an operation without pain medicine unless you pay a little bit under the table, which to me, that's barbarism, really. But
It suggests that the resource is there.
it is there, yes. It is there for those that can pay. But I agree with you with your general comment on there. Sorry, go ahead.
I'm sorry. Did they see that suffering as almost as a spiritual act that they're doing their?
I think that was part of it. I couldn't quite get in their heads, but yes. I mean, if you look at what Tibetan Buddhists do to kind of work out their religion, a lot of it has to do with purposeful suffering, going going on your hands and knees for hundreds of miles, to kind of. So I think there's an aspect of that.
Did you find resistance to medications with that spiritual practice?
Even after having lived there 12 years, there's still parts of the rationale and mindset that I don't quite understand about that. And there very well could be that, but I didn't get a good feel for that myself. But you could be onto something.
In my little tiny bit of experience, I'm kind of seeing a couple categories where there's this natural decline, which at least here we're seeing a lot of dementia, it's aging out, versus a disease-caused death. And what did you see there in terms of dementia care, or we can help somebody live in dementia for 10 years here,
Yes.
or they can choose to stop eating or do different things. But what did you see?
You would have many situations where you'd have grandma or grandpa in the care that was basically just on a bed, just lying there for years. They didn't have a terminal illness, but they were just getting old, and they just didn't have the strength to get out of bed. And usually those kind of people died from infections from bed sores, respiratory infections, something like that. But sometimes they could live for years and years that way.
Were they fed when they couldn't feed themselves?
They were fed, yeah. That's one part of often Asian culture, but I know especially for Mongolia, but most Asian cultures, there is an extreme respect for the elderly. And that's one thing that's a little bit sad, to be honest, about American culture, is that we tend to isolate our elderly in nursing homes and things. And yeah, that whole nursing home model was foreign in Mongolia, and I don't necessarily think the nursing home model is the best answer either, but they would be fed, yes. And they didn't always know medically trained, about how to prevent bed sores and things, but they did honor them and try to take care of them in the home.
And what did you observe as a determination of when they might stop feeding or allow that natural decline to occur?
The exact, point that happens, not sure exactly, but yeah, but I think they would still try to feed them. They wouldn't let them just kind of dehydrate and go out that way. They were still trying to feed them as long as they could swallow. If they can't swallow anymore, I saw people die that way, and that doesn't usually take very long. But as long as they could eat, they would still try to feed them.
So the idea of quality of life, the way we talk about it now, so a person bedridden for 10 years, that was still seen as an acceptable quality of life.
It's just because that's all they've observed. That kind of went back generations too.
Yeah. No judgment intended.
Yes.
Just
Yeah.
trying to see what you saw there.
Yeah. Again, the life expectancy was significantly less than here, so you didn't have that many people in their 80s or 90s even, who had that kind of severe dementia. The vast majority of the elderly are dying in their 60s, so that whole dementia aspect is not as great there.
I do know that besides shamanism and Tibetan Hinduism, that there is a fairly significant Muslim population in Mongolia. And my experience internationally was nursing in Muslim countries in the Arab world. And one of the things that I saw that I thought was interesting was that most Muslims do not believe that life is still pointless if you don't have quality. Because they have that belief that Allah makes all decisions. And they don't really, unlike us, kind of, our first question when we get a terminal diagnosis is, well, doctor, how much time do I have? That's not a question that they question. It's not a question that they ask, because they assume that Allah knows, and that will come when it's supposed to. So, in terms of how much quality of life they're going to enjoy up until that point of death, seems to be a bit irrelevant as long as they have some control. And some of that control is over pain, dignity, and privacy. Those seem to be the biggest things that they want. And so being the hospital doesn't really allow for much of that. And so you see the elders at home often. There'll be older people in a home, and you'll never know it because you never hear them talked about, and they don't ever come outside. And so it's very much a closed, kind of private kind of deterioration. And I guess they believe that's quality because it's respectful of those wishes.
Yeah, privacy is a pretty much a non-existent value in Mongolian culture, just because of necessity. If you've got 3 generations or more living in a tent that's smaller than around here, that has to be mobile, there's no privacy. There's not. Everybody lives in the same room, and so everything is done in that room. And how they have more Mongolians, I don't know how that all works, but yeah, but that it just doesn't work on the privacy standpoint. But there is definitely this respect for the elderly, and that was actually very refreshing for me to be in a culture like that, and to see that people, with some gray hairs, their opinions are respected, and I think we lose something out when we have a culture that doesn't always value the wisdom that's gained after you've been living for a few years like this. And
Do you think you'll go back?
to Mongolia?
Yes.
Well, here's the thing on that. We left Mongolia a bit under duress. These 2 children that we adopted, the government was not real thrilled that we adopted these children. And as soon as we got the official paperwork, we felt like we needed to leave the country for our family's safety sake. And still to this day, there are some people in power in the Ministry of Social Welfare that are still there from our time. So I wouldn't feel comfortable, even though they're American citizens, they got their American passport. It was actually a miracle how this is the first time that we're aware of that 2 non-siblings were adopted by a foreign family ever in Mongolian history. And we weren't going to give up on these kids. They were living with us. We had official foster care rights, and we used every influence that we could, and sometimes we were able to go above the people who had the power to, and so they basically were forced to sign the papers against their will because we lived there so long. We knew people in power, but they were not very happy about it, and we really were concerned about our safety. So we do plan to go back. We want our children to be able to see Mongolia again, but feel like right now is not the right time. If that makes sense to you.
I bet you there was a whole lot of praying going on.
There were people, honestly, thousands of people praying all over the world because they knew about this situation, and it was a testimony that prayer does do something. And but our children are miracle children. And
was there any element of fear about afterlife, that reluctant to address the aspects, the facts of death, specifically because of what comes next, the beliefs about what comes next?
Yeah, of course, either in the shamanist worldview or in Tibetan Buddhist, how your life in the afterlife is very much affected by how you treated people in this life. So for those that knew that they had mistreated people and only lived for themselves their whole life, there was fear to die. For those that felt like they had lived as a servant and lived to try to help other people, they were not as afraid to die. I don't know if that answers what you were thinking, but...
Is there any advanced directives over there?
That was the next stage, about really getting those written down. That to be honest, that had not really developed to that level yet. There probably is now. I mean, it's been 5 years since I've been in Mongolia, so I would not be surprised if that is going on now.
Was hospice care primarily medical, or did it address some of the spiritual and social
Yeah.
psychodynamics as well?
It was actually primarily non-medical. Basically helping the family members deal with dying, about social work issues, about how to help them financially, or who's going to do what afterwards, to help children, because everything's right in the home. They see these people dying, help children to process death, those kind of things. And then there was a spiritual aspect of it. It was not proselytizing per se, but they knew that the people who were involved in care were Christians, and then they would ask, why are you doing this? Why do you care about my grandfather who you've never met, and come here day after day and help to change things and just take care of them? And they went, why are you doing that? So there was some aspect of that, and amazingly, a lot of patients actually said that before they died they wanted to convert to Christianity, and it was a serious conversion, because for them to, not only to convert, but to say I want a Christian funeral. So to say that means that they would publicly declare before their whole family that they converted, and there would be some persecution for that. But then, actually, more people became Christians, not the person who died, but the family members, because they saw that there was something to this, that they cared for people in a way that was different than the healthcare providers who were part of the system. So it was kind of a total thing. I mean, medical care was definitely a part of it, but there were so many other parts of hospice care that was, in a sense, non-medical.
So hospice is a Christian-based concept?
Not necessarily Christian, but comparatively to the other predominant worldviews that were there, where you would see someone worth taking care of and worth treating with dignity and respect, no matter what they seem to be utilitarian part of society. So once they couldn't produce anymore, but they were still worthy of taking good care of. And that we're talking about old people a lot, but actually a lot of the hospice that we did there was not old people. It was young people who had cancers, big tumors that were growing on the side of their face, and or handicapped people, some of the type of mentally or physically handicapped that would be able to be productive here. They just didn't have the resources to take care of them, so they would be dying of other simple infections that they shouldn't die from. But because you didn't have the resources, sometimes hospice would have to get involved just because there was nothing else to do to help them right then. So I don't think hospice is necessarily a Christian concept, but there are certain worldviews that hospice would fit in more than others. I would say that.
Did you guys do all this self-funded, or did you get help from the government?
Not self-funded exactly. There was absolutely no help from the government. They did not see this as a priority at all. So family members actually contributed a small amount. They would contribute often with food for the patient, and help a little bit with just some expenses, like for bandages and different things. So it was not really funded from the outside per se, but it was. But we're talking, really minimal costs. This is not hospice like done here. We're talking probably 50 cents a day for patients, something like that. But I think now that hospice is, I mentioned, part of the system. So there should be some government funding now. But for that first few years, till they really saw how it works, there was not a single dollar that came from the government.
I just think it's so interesting, in such a dense population comparatively, to have 1 million people in one city, and have something like that travel so quickly, when we can't seem to get things from one edge of the country to another. We have the internet. Like, how'd that happen? I just think that's miraculous, that would evolve so quickly, something that was so really grassroots in that way. It wasn't being supported from the top down. It was something that people could feel, and then that word of mouth essentially had to have been what...
Well, it's word of mouth, but also activism. This guy, our director, was on TV a lot, and any type of rallies and for different things. This was not the only part of the healthcare system that was being revolutionized. everything was being revolutionized. This whole concept about these separate hospitals that I mentioned. And when you bring in family medicine and basically retraining all the specialists to kind of look at the whole person and everything. And so the whole system was kind of up topsy-turvy. But it was grassroots, but not just grassroots. There were some active ways to kind of educate the public about things. So.
I think one of our biggest obstacles really is not in Mongolia. It sounds like they're much like we used to be, born at home, die at home, and you're around it. And there's no.
Born in the hospital, die at home is actually.
But they're familiar with it, and there doesn't appear or sound like there's big money behind healthcare. And I think here in the United States, it's unfortunate, but it's true. There is money behind healthcare, and that unfortunately equals hope in a lot of instances that I don't think are truly strong. So even though we know that palliative care is right and that it's what we need to do, we have to fight against that corporate machine that has become our healthcare. You know? And maybe that's saying too much, but just.
So if you wouldn't mind me asking a question to the group, how do we change American culture and American healthcare culture to really make it more open and embracing to hospice? Since you all are the experts, I'm not actually doing hospice myself now. So.
One thing we have to do is let doctors off the hook. Stop expecting so much, and let doctors relax about saying, we have no more to offer you. And that's the role of the physician, and at that time, and coming to that understanding and making that decision is very crucial. And it's not by any means universally celebrated, that idea. So I think medical education and support for physicians to be able to let go of that hero, miracle worker, those terrible expectations that we have of physicians.
It's kind of this idea that death is a failure.
Yeah, exactly.
Yeah, that heroic medicine.
And ego gets involved in things that are just not appropriate when you're patient-centered.
It seems so much more complicated than that. I mean, that's a really integral part, because I think that's where it starts, for sure. And we see that oftentimes where people say, well, my doctor didn't talk about it. So they do have that responsibility sort of given to someone else. But I think that separation from death is a huge part, right? Because I think we're born, we have a life, and we might die. And that seems to be what most Americans think. Like, maybe. And it's funny when people are polled and they're not sort of in our circle or already talking about it and aware of it. They're like, well, I don't know if I'll die. There is that moment where they're just like, oh. It's because we are so removed. And it's not just from life and death, which is a major part when we're talking about this, but we're not in farming communities. We don't know how animals are killed. People don't even know what a chicken looks like in bigger cities. So there are those pieces where I feel like we're so detached from real life that it's hard to sort of bring that back, unless you can get New York City to switch on a dime. That's going to be a tough one, So I think that's a part where I think our culture has separated ourselves from it, and it's not something that's really acceptable to talk about either. And how do you bring about that awareness without the shock factor of people just saying, oh my gosh, you can't talk to me about death, or I don't know what I'll do if my mom dies. Those sorts of things are said often.
And how do we make it just a comfortable, normal part of conversation and talking about dying? It's just it's a taboo subject, actually, for most people here, and it's shunned. And it happens in the hospital, and a few people see that, or in a nursing home. But as I said, most Americans have never seen someone die, and it's a foreign. They don't know how to handle it.
And it's interesting at the same time with the Boston Marathon bombing, and our culture's so fascinated with violence. And we just can't turn away, and it's almost this piece inside of us that almost knows it's there but can't face it in that way. It has to be a different way. I don't know.
It is ironic, isn't it?
Yeah. Right. And that's sort of what Elizabeth Kubler-Ross had said, is that we have this fascination with that because it's like, that's not me.
Yeah.
Well, that wasn't me this time. You kind of feel like you escape that in a way.
Yeah.
And so I think that that's an interesting piece where we're watching the next person go and that sort of release us of that, like, I made it, I must still be okay. You know, it's an interesting dynamic there.
And to be perfectly honest, our culture has an exaltation of youth. We do everything we can to prevent a wrinkle coming on our face. And that I think is, again, trying to not have to think about death or dying or getting older. And every day I see patients in my office that are so distraught that they're starting to get older, as if it's not a natural process, but it is a natural process.
I think we can really look, and we talk about this at other community conversations, but we can really look to the birthing movement, because there was a time where most births happened at home, and then all of a sudden they had to happen in the hospital, and you had to have anesthesia, and then for whatever reason, lots of different social movements, people kind of looked at that and thought, well, that doesn't have to be that way. We can take birth back, and we can create options and revisit. But it came from educating ourselves about birth and being able to go in and say to the professional, well, what about this? And reassuring the professional, they don't have to be the expert, because I'm going to bring some information in too. And then the expert being willing to meet me there. So I think that we can look at that as some inspiration on how we create some social change. I'm telling you, I'm still just, my jaw drops when I look at what we've done with cigarette smoking in my adult life. Because when I was in high school, it was kind of starting to be trendy to have smoking lounges for students in high schools, because cigarettes had become so socially acceptable in the 70s, and then all of a sudden, bam, in the 80s, it's like, we're not going to smoke anymore. And it just, so I feel like if we can create that kind of social change in healthcare and in awareness and personal choice, you know, we could do it with death and dying, and take that back and educate ourselves through conversations like this and professionals like you who are willing to talk about other ways.
I can tell you, from having practiced a good part of my professional career in a non-American setting, you can provide very, very good quality care for hardly any money. I operated an international clinic there, and I had access to a lot of the same medicines here, and without the pressure, or to be honest, the legal system behind you, you can do a lot. Even if you don't have an X-ray machine or MRI, you know, just the Marcus Welby listening with a stethoscope, and extremely inexpensive. It saddens me to see, honestly, where American medicine is going with the technology, but not necessarily improving quality of life, and just getting more and more expensive. I mean, you know all the statistics. We have the most expensive healthcare system in the world, but by far we don't have the best statistics. We've got to do something. I know everybody's kind of complaining about Obamacare, but we've got to do something. We can't keep increasing the percentage of GDP in healthcare in this country. It's bankrupting our country. I'm a believer in tort reform. I mean, these lawyers are saying that it's only contributing, you know, a fraction, you know, 0.5% toward healthcare costs. That's not true. There are so much other things that are done in medicine because you're worried that the standard of care is that you're going to be sued about something, and that's just the reality of it. It's not because you think that's best for the patient. It's because someone that you think a lawyer could say, why didn't you do that test? That would have found that cancer, kind of a thing. And it's terrible. It's not good quality medicine. And so we need to have a movement like you're talking about there, how to get back control of medicine, because something's terribly wrong with the way we do it in this country, in my opinion. But
it is so refreshing to hear you say that. A doctor, my heart swells with joy to hear you speak these words. Myself, I was a struggling single mother for a lot of years and worked 3 jobs and worked very hard, and certainly the last thing that I had money for was medical care. And out of necessity, I learned a lot from books and herbs and vitamins, and I became very proficient at dropping my kids' high fevers 2 and 3 degrees within an hour with megadose vitamin C in juice on a blender. And for 1 solid year, I prayed over 3 glasses of water and asked God to provide every nutrient that we needed. And we stayed well until we moved, and I forgot to charge the water with prayer, and we all got sick. But my point is that there's so much we can do through folk medicine, through the power of prayer, positive thinking, or higher power, along with change. I mean, we all know, how crooked the medical monopoly is and big pharma. I mean, I've worked against it for years, and I've proven, just as a wobbly single mother, that I could keep my kids well and I could heal them.
Well, amen to that too. So one other quick soapbox, not quite directly related to hospice, but one other shift that I think really needs to happen in the American medical care system is to put responsibility back on patients. There's so much this thing that you can live however you like, and you go to the doctor and the doctor's going to fix it. That's why we have a expensive healthcare system. People do not take responsibility for their own bodies. And that's part of the way I practice, that I can say something, but it's your responsibility to look out for your own body. And patients don't like it. They don't want to be responsible. And that's unfortunate, but they don't. They want you to fix it easy with a pill, and then they can just do whatever they want rest-wise. And it's a twisted, backward system. And
that was the point that I meant to make, that when they say take doctors off the hook, that's the hook. That take care of me so I don't have to take care of me. Fix me. And that expectation. And it's sincere. It's a sincere belief that there are miracles and you're withholding them from me. Somehow it's not universal, but a lot of people have that both fear and anger at doctors.
I'm also a public health person. I have a degree in public health, and people say that it's biased or discriminatory if you don't provide every technology or whatever to every person, but it is not. I'm a big believer in tiered system. If people can pay for it and they want to pay for it, you can do all this stuff, but you can provide, as I mentioned, really, really very good quality care for a small fraction of what the standard of care is in this country. If you can remove the fear of getting sued, and if you just work with people in a kind of a practical approach and saying, we can do these tests, but I'm probably 95% sure that this is what you got. You got a 5% chance you got this other thing, but why don't we just do this without doing all the tests? And I mean, you're going to be right most of the time. That 5% you're not right, you get sued and you're out of business. That's why it's expensive. And I think that goes back even to the, with hospice stuff, that hospice is a very cost-effective way to end our lives compared to being in the ICU for the last 2 weeks and spend $100,000.
You're talking about kind of Mongolia in the U.S., but there's a lot of different cultures, and we're sitting here, I think, mostly white, mostly fairly wealthy compared to the rest of the world. I think we have a sense of entitlement to live to be 90, even if we look at our parents and say, oh, Jesus, please don't ever let me live to be 90. It's like, well, we want to cut that off, but I think if this room were half full of young black men who might have a life expectancy of 45 years, we'd be talking about different, there's a lot of subcultures in the U.S. that don't have even the tween of the 90. But a really good article, and I think it was from the hospice Facebook page, about the doctor talking about the roadmaps in end-of-life care. Did anybody else read that by any chance? I did. They send stuff out on Facebook, and it's constantly good stuff. But he was saying that, like you're talking about, do I have to provide every single thing? My mom's 89, she has dementia, she has a neck that's been broken for 2 years, one doctor said. hopes it'll finish falling off someday. That was 2 years ago. She's very frail and she has a really high quality of life right now. But if she gets sick, or if she gets an infection, or if she gets whatever, I believe her wishes are to not prolong things. And so they're saying, make sure you've got that roadmap, make sure you've got a roadmap for your parents, and then talk about that roadmap with the doctor. Because if you can't talk about it, then they have to offer every possible thing you can come up with. But if you could say, now, why are we treating this, infection as if we're going to have him living for another 30 years when he's probably got a few months?
Yeah.
And if you say that's the roadmap, and all of you can agree to follow that roadmap.
And one of the things I think we need to do better on, again, there's this guilt complex with family members to say that you need to do everything. It's usually not the patients themselves that want everything done. It's the family members that want that. And how we can relieve the burden. Say, I know you still love your spouse, or you love your mom or dad, but loving it doesn't mean you have to do everything that's available to prolong their life a short time. And that's, if we can somehow better communicate that to relieve that guilt from family members, we go a long way to keeping people out of the ICU that last week and let them to go home. And to be, that kind of romantic idea that you have your whole family members surrounded around your bed as you say your last breath hardly ever happens in this country.
I think 100 years ago, I think that life expectancy was like 50 years or something.
Yeah, it's really gone up.
So if you look at that and say, wow, just way past that.
We're in bonus years.
You just one out of us. My question really, we were talking about hospice and end of life specifically in the U.S. How does that dance go for you? As a practitioner, when you have people that come in, is it patients that are bringing it up that say, man, I heard hospice is so awesome, when am I going to be ready? Or is it something that you have to feel like you gingerly lead people towards? Like, how does that dynamic go?
I've never had that happen, where patient says, hospice is so great, bring it on, kind of a thing.
Yeah. Like, when am I ready? Sign me up.
No, and I wish it would be more just as part of the conversation. I mean, American culture and all cultures are influenced by art and media. I bet there's no TV show on, maybe apart from a reality show, I don't know if there is, but that shows people dying with dignity in a hospice situation. It's not part of any type of sitcom or drama on TV. It doesn't look like a normal part of life. Usually they say like art precedes philosophical changes, usually by a generation. And if we don't have our media and things like that kind of representing this, it's just not part of the way people think.
The one show I can think of that did pretty well.
What's that?
It's Willy Wonka and the Chocolate Factory.
Grandparents do that.
Grandparents do that.
Yeah, you just have them all in one house.
Kids sleeping at the other end, the other direction.
It takes a long time in the doctor's office to really kind of talk through this with patients, and generally I don't have time to do that. So there have been a few patients that want me to talk about it, but it takes half hour, 45 minutes to kind of work through all the different scenarios and what you want done. We're moving more toward what's called a medical home model, where you have all kinds of different levels of healthcare practitioners working as a team. That's the way medicine's going. It's a good thing. You can't have the doctor spending 45 minutes going over different things for hospice. It's not a very time-efficient way, but you can have other people in the healthcare system working together to do that. But it still needs to happen. It's not happening at all right now. So, go ahead, sir.
There are a couple of themes that came up earlier that kind of came together for me and made sense in a way that it hadn't before. And one was the comments of talking about how difficult it is for us to deal with death, and how much of a taboo subject that is, and how uncomfortable families and we generally are. And the other, I wanted to come back to the point about the very powerful incentives inside pharmaceutical and medical providers, the medical establishment, for continuing treatment and for peddling hope. And my experience has been with a focus on giving hope where it really defied my common sense that hope was a reasonable thing to be doing. And being a bit of a cynic, it's easy for me to see that driven, at least in part, by the powerful economic incentives for yet one more treatment. And I think that the medical profession has to take some major responsibility for that. And I think the recent article in Time provided some really interesting documentation for the ways in which our medical system frequently becomes abused, where the choices between trying to pursue improbable hope through expensive treatments, as opposed to the option of relaxing back into some sort of palliative care. And so it seems to me that that's a major problem, and it's one that could be addressed in part by making it easier for us to talk about deaths and for families to process that prospect. But it seems also that there's work that needs to be done in terms of the economic incentives that the medical profession is faced with.
I agree. And how do we do that?
We've got a lot of smart people here. Can't we just fix it today?
It all happens at once because doctors are patients, people are doctors, people are nurses. We have our roles and we have our labels, but we're also citizens, and we're all going to die, and we're all going to have something to do with birth and everything in between. And I think although each kind of role or segment has its particular responsibility, it's a zeitgeist. It's like a wave that passes through, and I think it's happening, and I have had a really hard time wearing my skull earrings because Hospice of Missoula has a part in the Festival for the Dead, and everyone has these lovely skull earrings and very cheerful, bright colors, and I spent a lot of my time as a care provider trying not to stand out, trying not to be part of where the attention is going. So I don't want my clients or my patients to focus on me. I want the focus to be on them. So if I'm wearing skull earrings, that's shocking. It shocks people. And I'm not sure that it's my role to shock people as a representative of hospice. I have a struggle with that. And it's on the other hand, I love the people that I work with who are more accustomed to and comfortable with being bright and shiny and more comfortable with attention as art, representative art. So I like being part of particularly this hospice that is very colorful and exuberant and cheerful about our work. Because we should be. But I'm also aware of this sensitivity in me to not be shocking, or what I'm interpreting as shocking. So that's also, there's a sort of delicacy that is also part of introducing the topic. You're cheerful about death, you're dancing about death, you're what? You're getting dressed up about death. And that would be the thing to do. That would be the thing to do. To make it, oh boy, you're going! And that would, that has to do a lot with what we think happens next, of course. And that's a whole nother role, that's a whole nother aspect of.
Well, that's part of the beauty of what makes our team, I think, and all hospices, honestly, just so fundamentally beneficial, is that your job when you're a caregiver isn't to be anything except for to help that person with their patients. And maybe you'll have some patients that are like that and they would be comfortable with Day of the Dead garb and they're going to be celebrating it, or maybe they're Tibetan Buddhist and they understand that there will be suffering. I mean, whatever that path is for that person, it's just to respect them in a way that you're invisible, and I think that's entirely true. You know, so maybe as an organization we try and push end of life in that way, being out in the community saying we should be accepting of this. But when it's one-on-one, you're right. I can see why that would be so intimate and in a place where you're wanting to respect people's wishes and not offend in any way. Makes sense.
It's interesting too, like, that just reminded me, and I love that you guys are part of that Day of the Dead celebration. I think that's so neat in the arts. But it seems like with a lot of big movements, like just recently with the gay marriage movement, that there's like one group really pushing, and then there's Ellen DeGeneres, this kind of jester who's coming in from a different angle and winning over people's hearts in this like sideways artistic way. That's kind of fun, and it's a bunch of different pieces to a whole movement. Too.
Yeah.
You know,
Well, here I am with my skull earrings on. One of about 7 pair that I have. But you know, it's a great reminder, and I'm trying to think about honesty and authenticity and what they represent to me isn't necessarily what they might represent to the person I'm talking to. So my job then, if I'm going to wear these and work for hospice and try to be edgy but also sensitive, is to create a space of honesty so that the father can say on the phone, you know, you were at my house and you had that bracelet on with the skull on it. That made me really uncomfortable. And I could hear that and think, probably better think a little bit more about when I wear things and what I wear and where I wear them. But I felt really grateful that there was that place of honesty.
Yeah,
that he could say that.
That's what
and
matters.
that I could still push him into that edginess where he could say it. So yeah, it's so individual. It's just so, we're just all in our own very own personal space with death and symbolism. It's a great topic, earrings and skulls.
Well, yeah, well, Dr. Ihrig said, you know, where does it start and where do we go? And I think out of all the themes that we've talked about tonight, quality of life and honesty, quality of the relationships between people, that it kind of boils down to a word that I'd like to say is as simple as permission. And each one of us and each other person, I think, works in their own way to give people permission to follow their own heart and permission to be honest. We have permission to educate, and most of all, for physicians to have the permission to say, you know, I think we've done all we can. Let's work on quality. Let's work on the transition of your goals. And to give families, and I find that as hospice nurses, social workers, certified nurses assistants, all of the professionals that enter the home, we're giving family permission to let down one huge guard that they've held for a good long time and just get down to the bare necessities of taking care of one another. So maybe those earrings give somebody permission to entertain the thought of death. I wear mine out on a Saturday evening, but I never wear mine to patients' homes. And so I think I give my permission another way. And you all give your permissions too, I think, in a different way as well. We're kind of nearing a time of the evening where we'd like to just go around the room and briefly, succinctly, if each one of you could say, what themes stood out to you? What did you hear tonight that was meaningful that you will take with you and perhaps maybe share with another individual tomorrow or during the next week? Okay. Can we start with Marika?
I'll go last. No, you don't want to go first? Okay, I'll go first. I guess, you know, it's very similar every time we have a community conversation. For me, I just feel full of energy, and I really love how people can get together in a group like this and speak so authentically, and I don't see that in everyday life. You know, I don't see that happening outside of our work, really, where people can get together and share something that is so sort of taboo, and how you feel about it and what you want to do about it. So that energy fills me up to do the work that we do, and I love that you guys are here doing that. I think that I'm really grateful, and I do want to figure out ways of spreading the word and not being, you know, embarrassed, giving other people permission to talk about it. So it's definitely a great piece. I'll take that for sure.
I really liked the idea of the grassroots movement with this big scary medical system, and I know being a student in it, seeing how it's a pretty big force, but I like the idea of this grassroots movement and hopefully different movements making some pretty big change. And I did tell my nursing class that I'm such a believer in hospice. Like, if I get a paper cut, like, put me on hospice.
That would be palliative. I loved hearing how the hospice concept just took off. Gosh, I'm just klutz up. Took off in Mongolia, and my observation in talking to people here that gives me hope is that it sure feels like in the United States, once a hospice family, always a hospice family. Once a family's utilized and been touched by a hospice service, they're not gonna go any other way.
Try to do it without talking too long, I guess. I think there was a bunch of times that I was going to chime in, but we had a great conversation. I think what I take away from it and what I relate it to is the fact that small movements do grow, and they grow fast. I think about 10 years ago when I was in high school, and it's the very first time that with homosexuality, there was 2 kids in our school that came out, and they were treated so badly because it was taboo. You know, it wasn't okay. And now that is not the case, and it's been only 10 years, you know, since I've been in high school. And so in 10 years we've made great progress there, but there's been a lot of people that have been pushing for that. And I think with this, you know, we've been there before, and we can work our way back to it again. We just all have to be on the same page and talk about it. I think talking about it is the most important. And not to keep babbling on, but I was thinking while you were thinking, you know, why I was in my bachelor's program, it was when Obamacare was being pushed through, and people started talking about the death panels and how you can't have death panels, even though that wasn't ever even really an option. You know, it was what people perceived to be a death panel. But I think I was talking to Lawrence. He just got back from New Zealand with you and Australia. Yes, sorry. And I said, well, how was it? He made the comment that he had come back from tomorrow. You know, and we were talking about that and how over there it seems like it's tomorrow because of the way that they are. It's the way that he hopes that tomorrow will be here. You know, essentially their hospitals meet with wards that are full of different people and talk about cases. Like an oncologist sits down with a palliative care doctor and says, this is the case, and this is how long we've done chemotherapy for, this is the current situation, what's the plan? And they go forward and say, well, let's try another chemo session, or it's palliative care time. And I think about during my bachelor's program, I had to do a study on, and a research project on government-funded medicine, you know, and all the different countries that I looked into, and of course not all of them are perfect, and a lot of people hate them. But there are certain things like gatekeepers that I think maybe that wouldn't be such a bad thing, to have somebody that's reviewing that medical chart to make sure that we're not going to see these specialists for no reason. Or in some countries, the physicians are all employees of the government, and they receive an annual salary, and there's not a fee-for-service type situation set up there. And then I think of our hospice, the way that the hospice reimbursement rate is, and I don't know if all of you are familiar with that or not, but basically Medicare pays hospice a daily rate, you know, per patient that we see. And we don't get any more than that, we don't get any less than that, but that's what we have to take care of our patients with. And rather than saying, we went out and saw this person 7 times a week, pay us 7 times. They're gonna pay us 7 days of the week, the same amount, we get to cover everything with that. And I think if we see more of that, you know, besides DRGs, we've gotta go above DRGs and do different things than that. And I think we're starting to, but if we see more of that, we'll start to come around a little bit more and decrease that cost.
I agree with Marika. I'm just grateful for the hospice and how much it's progressed and how I'm just grateful for it. It's came a long way. It's very helpful for a lot of people and their families, and it's just a great thing to have.
Half of you in here have heard me say that I've died and come back twice, and you know, it's the most profoundly normal conclusion to living. It is the easiest thing you will ever do. It's a blink of an eye and you're looking down at that beat up old baggage of a body, and you're exorbitant and you soar. And most people do report the white tunnel, the tunnel of light, which I experienced. And there stood all my family, deceased before me, waiting with open arms to welcome me. And there was a banquet laid out of every succulent meat and beautiful food and salads. It was a party. And the profound feeling of the love of, I'm a Christian, of the love of Christ. There's no way on this earth I can describe the beauty or the profundity of that experience, that deep cellular knowing. And you know, I just have to share quickly with you about my Aunt Lil. Aunt Lil was a rounder. And she was married a lot of times, and she had a lot of boyfriends, and she drank a lot of booze in her day. And she was dying. She was in the death throes. And the family now, 4 months into this, and they're exhausted doing the bedside vigil. And they said, Nikki, you've got such a way about you. Come and talk to Aunt Lil. I stood by Aunt Lil and I said, Aunt Lil, you're almost done. And there's a party waiting. And Dick and Ralph and Elmo and John, all your husbands, are all waiting to party with you. Now she'd been lingering, and you know, I would have never lied to her. You know, I can speak to spirits, I can talk to people crossed over. I have some psychic ability. And they're all like, get her over here, we want a party. You know, she died that night. And she died with a smile on her face. And they called me up and they said, Nikki, what did you do? And it scared me half to death because I thought, oh my God, they're gonna think you did something weird. The truth of the matter was, she was sticking around because they wanted her to be there, and all she wanted to do was go up to heaven and have that party. So my point in this is to say to you that it's the most natural thing in the world, and this, I believe, is where the world is going to begin to change, is through you folks and people like us. And sir, may I say, you have been so delightful, and your honesty and integrity just pours off of you. You look so darn normal to be such a wise soul. I thank you so much.
My pleasure.
I'm just gonna have to say that I was really surprised at how kind of quickly the hospice has kind of picked up in other parts of the world, and that how surprisingly slow it's moving here, and how everything is just so slow moving here. And I just kind of agreeing with everybody about how trying to figure out ways we can make it go quicker and get hospice more recognized. Not even necessarily just our hospice, just hospice in general. Having death become less of a taboo. So I'm just kind of along with everybody trying to hope that it goes quicker and more recognized, and trying to figure out ways to do that. So.
Mine goes along with the same with his. My first introduction to hospice was when he got hired onto a hospice. Up till that point, it was just a medical term. That's what happened when you got old. That just, you know, it was just completely unknown to me. I had no idea it was for, you know, other people as well. It was, so when he said he joined the hospice team, I was just like, what is that? And it fascinates me that Mongolia, you know, the secluded country way on the other side of the world, hears about this and wants it there, and it spreads like fire. And I didn't know until nearly college that I had no idea what this was. It's very surprising, and I learn new things every time I come of different things hospice does and how wonderful it is. And it's amazing that it just stops here, but everywhere else it's spreading like wildfire, and it just kind of needs to do that here as well.
Ditto.
Nice try.
I thought the story that Rapid Spread Mongolia was just wonderful, and it's wonderful work, and it was really interesting. I think Nancy's comment about the wonderful hospice stories that people have, I've encountered too, mentioning how wonderful hospice was in Mary's death, and then people say, oh yes, hospice came in, and these stories are out there, and it baffles me as to why it's difficult to parlay that into a more powerful grassroots movement of some sort. And so part of what I'm leaving with today is bafflement over that.
Well, I don't know all that much about hospice, and I don't know the struggle that everyone's been talking about. I mean, I've been in Portland the last couple of months, and every hospital has a big hospice program. So I don't exactly know enough to know about the stalling that everyone's mentioned here. Here we all are, and hospice seems to be something that is a part of the Missoula, the different hospitals and that kind of. Anyway, I just found that, so I think that's interesting, and I would be interested in looking more into what's really going on with that. Mm-hmm. And also I was really interested in Mongolia, so I was fascinated and thinking about different cultures and how they might have had to change in recent years in dealing with their loved ones as they pass away. So I wanted to find out more about that, and I found that to be really interesting. And the fact that it spread so quickly, amazing and positive. So.
I'm aware that some of us here have experienced very recent deaths. I appreciate your presence. I appreciate that you're out and being with us at this time in your lives. And the other thing that I'm really touched by is the young people. Thank you. Thank you. Because you're who is going to make it happen. It's where it's got to be there. So thank you for coming.
Thank you very much. It was, again, a wonderful conversation. And I've been thinking about your comment about art. And how did you say that? Art and something preceding the changes in culture.
Yeah. Art and media. Yeah.
That's what I'm taking away. You're mentioning Stories Lee. This person that we visited in Australia has just published a book that's full of stories about the work that he does there. I'm curious more about art, visual arts, and dramatic arts. And that's what I'm going to go away with, is looking more into what's happened in the past as far as those changing culture, and trying to imagine how that could affect change here. Thank you.
I want to just make one comment on that. It was so fascinating as my little amateur sociologist over there to watch Mongolian culture change based on art and media. In other words, when they started getting open to Western culture, they would have American TV shows or American music or whatever, and you would just see the young people morph into semi-Americans over there, and what they listened to, how they talked, what they wore, what their conversations were about. And I am so convinced that art and media is the way to change a culture. I mean, Hollywood has an inordinate amount of influence around the world, inordinate amount. And we need to get people in Hollywood who are passionate about hospice, and they can integrate them into TV shows, into music, into visual arts and everything, and that's how you change the culture. Yeah, yeah. Yes, exactly. That would. Yes. Mm-hmm. Mm-hmm. Mm-hmm.
partly being late, I didn't get to hear most of the Mongolia things, so I'm hoping that there is some recording. It sounded fascinating, and I too, I like what you said about the gay movement, and I think a lot of that has been through the media, and Ellen, and some of our superstars coming out and making it more normal. And I think that's true. I think we just have to continue talking about it, continue showing that death doesn't have to be so fearful, and there's a way through it. And hospice is a major part of navigating clearly banking on the last time I was here joyfully through the death process. So what I take away is for me to continue to talk about my experiences with hospice and helping people talk more openly about death and not being so afraid.
I also, sorry, missed it because I've had a long time interest in Mongolia and Mongolians. It kind of scares the shit out of me for you to say that young Mongolians are learning from American. I'd rather see them riding their horses. That's the
I agree.
steps. I am living with a stage 4 cancer diagnosis. I do not have an entitlement feeling that I should get to live to be 90, but I hope to have a while longer. Part of what I have had so far is a chance to become a lot more comfortable with the idea of dying. I could use some more time for that. But I think part of it is just if Americans, which I try to realize and I try to understand that 100 years ago people didn't live to be 90, and that in a lot of other countries and even in cultures in our own country people don't have that chance. And some of us may not get any chance to become comfortable dying. We just have it happen out of nowhere. But when you say that not very many Mongolians even live into their 60s, most of my relatives, I'm happy to live my life like a Mongolian.
Thank you for sharing that and for willing to come here and be vulnerable like that. I think that hospice does start with us here talking to the people in our lives, our families, our children, our brothers and sisters, our parents, and not just once in a while when it suits us, but like, I'm gonna go home and Facebook about this. This is what I learned at discussion tonight. What do y'all think about that? And I'm from Western Oregon. I know what you mean. It is hard to understand that hospice is not everywhere. It doesn't permeate culture. So yeah, just gonna keep talking about it to anyone who will let me until they're like, oh God, she's on it again. Thank you.
Well, thank you to Dr. Ihrig for being here tonight, sharing your experiences with us. I look back over that number of years that I've worked in a hospice setting, and I'll be the first to attest that even today, it is a sure way to stop a dinner conversation cold. to bring up what you do and to talk about the meaning of life that way. I think Rick is really right in that we somehow have lost the ability to talk about maybe one of the most intimate things in our lives with our family members and out in the public. And I'd like to get permission to get that back for us.
What kind of a doctor are you, if I might
I'm a family doctor.
Pardon?
Family medicine.
Okay, and you're here in Missoula?
I am.
And what is your last name again?
Ihrig. It's a funny one. It's a funny one. I'm looking at my badge. I don't have my badge on. Ihrig. It's a German. Ihrig. It's a German name, but Parkside Family Medicine.
Okay.
And thank you very much too for sharing your ideas. I mean, I'm as you can tell, I'm passionate about hospice, and it's wonderful to see other folks who are passionate about it too. And we all have to work together to get the word out. And so thank you for sharing your thoughts and opinions too. It's very informational for me too.